Uh, it's truly my pleasure to introduce everyone to Dr. Dan Morhaim. You all
Hi.
read a little bit of the thing. However, I've known Dan Morhaim since the early 80s. At that point, I had just started with the fire department. Dan was the Region 3 EMS director and also one of Baltimore County's fire surgeons at the time. And then when I was fortunate enough as a third year med student, Dan was my preceptor for my emergency medicine rotation. And I'll never forget showing up that very first day in my short little lab coat just to impress him. But so Dr. Morhaim has a very unique background. He's an emergency physician with over 40 years of experience. He was a Maryland State Legislature in the House of Delegates from 1995 to 2019, faculty at Johns Hopkins School of Public Health, healthcare consultant and author for numerous articles in medical and general media. He's published in the Johns Hopkins Press, Preparing a Better End. He's been on numerous health committees, including serving on Maryland's Behavioral Health Advisory Council, and I'm sure many committees through the Maryland legislature. Dr. Morhaim holds faculty appointments at the George Washington University and a new medical school in the state of Maryland, which is the Maryland College of Osteopathic Medicine at Morgan State University, which is just starting up. He's a staff physician at Sinai and Northwest Hospitals through LifeBridge Health in emergency medicine. And Dan brings with him much speaking and media experience in a broad range of audiences, dealing with community organizations, professional groups, all political settings, and just working with people. And additionally, what a lot of people don't know is he's an avid jogger. And I've seen him at many races. And when I do see him at these 5Ks, I make sure I snap pictures and text it to him. So without further ado, I'm going to bring Dr. Morhaim to you all.
Hi, everybody. I live in Pikesville. I know that you had a training session recently at the Pikesville Armory, right, Jeff? And my wife happens to be president of the Pikesville Armory Foundation, which is redeveloping the Armory, which is going to be quite a deal. Thank you for being patient. And thank you for all your service. I mean, we totally rely on you. So this talk is, I do several talks, how to be an effective citizen lobbyist, the opioid and overdose crisis. I'm talking with Ashley and Jeff about iron deficiency. For anybody that knows any women that are in reproductive age, iron every other day. That's the message there. And then end of life care. And, you know, usually when you bring up end of life care, everybody runs for the hills because who wants to talk about death and dying? But, you know, this for me, I can share a lot of the experience that I had, and I know you have had too, where I found myself in my career doing codes on people that I didn't think that they needed codes, but we had to do them anyways. And that got me interested in this topic more in depth. And we divide the world up into cohorts, the people that have this thing or that thing, kidney cancer, psoriasis, heart attacks. This is the cohort we're all in. So this is personal as well as political and policy-wise. So I'm going to switch to full screen and slides, and give me a second to share screen there. So Jeff, confirm everybody can see that. And Jeff, keep track of the people signing in because I was admitting them and you want to make sure you do that too. So that's my background. There's my book from Johns Hopkins Press. It's available on regular print, electronic, and also now on Audible. And I worked a lot of shifts in my life, just like you. Fortunately, I worked in a nice emergency room. You're out on the street dealing with people and accidents and all kinds of stuff. And my hat's off to you for doing that work. I was the founding chair of emergency medicine at Franklin Square for 13 years. And then started getting involved in some community stuff because so much I was seeing in the emergency room was social issues. Ran for office, got elected, served 24 years in the Maryland General Assembly. When I got elected, I moved over to Sinai, a little bit at Northwest, but mainly at Sinai until about 2019, when I finally stopped doing shifts. But I also worked on Navajo Indian Reservation, Saudi Arabia, Kuwait after Gulf War I, volunteered at a homeless clinic downtown, and for a number of years was on their board. So a range of clinical experiences, including, since the Orioles won, I got to say, I was the medical director for the 1983 Major League Baseball All-Star Game when it was in Baltimore. So that's my career, and let me advance these slides. And that's the book that I wrote. Feel free to get it. It's also at the library. Now let's dig into this. So 80% of us die over time. Only 20% die suddenly. So this is the audience participation part of this. And I can't see you, but we'll just have to fake it out here. Let's do this. How many people have been present when someone took their last breath in real life? And uh, for me, it was just once. My stepfather, my parents were, my father took off, my mother remarried out of the deal. I got a good stepfather, and he was on dialysis. And he decided finally he was deteriorating so bad he wasn't going to go back. We stayed with him, and he died quietly at home. Marked contrast to all the deaths I'd seen in my clinical life. Number two, this is going to be your ultimately your class assignment. Have you completed your own personal advance directive? I'd like to see a show of hands if this was a live audience, but if you have, great. If you haven't, that's what you need to do as soon as this conference is over or tomorrow. Now, let me ask you this question. We'll jump to number 4. When the end comes, got to think about this for 5 seconds. Where would you like to be? Who's around? What's going on? 5 seconds to think about that. Okay. Anybody say killed in a fiery car crash? No, nobody said that. Anybody say shot in a drive-by? Nobody said that. Anybody say die in an intensive care unit long past any hope of recovery, tied to tubes and monitors down and with my family down the hall? Nobody says that either. Now, don't get me wrong. I want the best of intensive care. If I have chest pain during this call, send out 911. I'll give you my address. But if I'm dying of stage, 18 pancreatic cancer, I don't want a septic shock death in the ICU like many people end up with. And so what most people say, what's going on, what would they like, is some version of, I want to be at home with my family and friends around me. I want to be pain-free. We can't, and I want to be comfortable. Look, we can't do anything about dying, but we can do a lot about the run-up. And what people fear, when you get right down to it, have lots of conversations and think about it, what we fear is pain, isolation, and dependency. And the amazing thing is all of those can be managed simply by completing free paperwork or taking advantage of free services that are available. So instead of the process of dying being some horrible, controlled experience by others, you can actually make it holistic, family-centered, meaningful experience. Let's sort of imagine back a couple hundred years ago or 100 years ago, sort of a happy mythic view. When somebody got sick, doctor couldn't do much, take their pulse, but he or she knew the family, and the doctor knew how to talk to folks about that. And somebody died, they were laid out in the parlor and buried in the graveyard in the back. We can kind of achieve some of that again now. So it is a hard topic. I get it. You got to imagine me running for office and going out into the community, doing community talks. And I would talk about all the things I worked on, which was many other issues. And then I'd say, I also want to talk about your death, the death of everybody you know. And by the way, don't forget to vote for me in the next election. Look, this is hard to bring up, just like it's hard to bring up a lot of things at times. For people to talk about cancer, it was hard for people to talk about a child with a learning disability and so on. So this is involving virtually everything. I got as many P's here as I could. It's public policy, still admitting people here. So why I'm distracted. I guess I'm a co-host, so I have to let them in. So public policy, prevention, public health, it's about empowerment, it's about finances, payment, preference, practical, and in the ultimately, it's personal. We are empowered. We are the first generation in human history that likely has some say about how we die. Nobody's ever had that before. I mean, 100 years ago, you stepped on a nail, you got something, and you were dead. It's a whole different issue now. So I got interested in this issue, and I asked Keisha Pollack, who is now chair of health policy at Hopkins, but then was a kind of intern staff in my legislative office. How many people completed advanced directives? Now you could look up how many people had renal failure, on dialysis, had sickle cell disease, had strokes, had broken hips. That was all available. But nobody had done the study on how many people completed advanced directives. And so I got a grant and we did the study. And what we found was that only about 40% of Americans, and this was, fancy study with t-tests and bar graphs and all the statistical analysis. But anyway, the punchline is only about 40% of Americans complete advanced directives. It was about half that in the minority population. So we were the first to identify that as a minority health disparity in a subsequent paper. Go back to this one. We asked people, if you don't have an advanced directive, would you like one? So 60% didn't have one, but 90% of the 60% said, yes, I would. And that's over 90% or 60%. That's over 50%. So a lot of people wanted it. We asked, where would you like to get information? And we gave them a range of choices, faith-based, internet, talk to friends, family. But overwhelmingly, they want to talk to their doctor or somebody in healthcare. That is to say, us. And so we followed up with another article in the American Journal of Public Health here, pointing out, we also had attorneys in there, but they want to have a clinical conversation, something that clinicians aren't trained to do, don't do well, or maybe want to do, but don't have the time when you're racing through that doctor's appointment. So let's just run through quickly what an advance directive is so you're all up to speed. And not only, you may know this, but one of our challenges is we have to be the agents that go out and talk to people. And so this is also to help you in your conversations with folks. And not only do I want you to complete your own advance directive, which is a very interesting exercise that only you can do. I can't do it. Jeff can't do it. Your rabbi, your minister, your imam can't do it. Your mother, your father can't do it. Only you. So first you have to choose a healthcare agent. These are the three choices, and we'll go through each one. So choose a healthcare agent. It's got to be somebody you trust. You should talk to them in advance. And in COVID and otherwise, people, brought in the ER, we don't know who they are. We want to know who to talk to. So if this is all you can do, choose a healthcare agent. I'll be personal. Mine is my wife first, Shelley. We're, good place. And so that makes sense. I've taken care of people and we didn't know who they were. And they said, well, call a spouse. And it turns out the spouse, they're in a bitter divorce. They hate each other. And if you'd known that, you might not have called the spouse, but that's the kind of thing that happens. Sometimes there's three kids in the family. One kid says, do everything for grandma. Another says, pull the plug in effect. And the third is in the middle, torn apart, let grandma die in peace. These are the kinds of challenges we face and you face too. So in my own family, I have three adult children. They're all good people. Two were on the same wavelength. The third one, not so much. So my advance directive says, if my wife isn't around, then the two will make the decision. I also ask that they consult with the third kid, and I also ask that they consult with a good friend of mine for medical school. But it boils down that I designate the other two. So what kind of care do you want? These are the three choices. You're familiar with the term do not resuscitate. I never liked that because I never knew how much was not to do. So at LifeBridge, it's called allowed natural death, which is much more friendly to me. And each of these choices, everything, little or nothing, may be, or middle path, which I'll get into in a second, may be appropriate at a certain time. And so if it's a cold water drowning death or a young person that is hit in the chest with a baseball, man, you're going to do everything, right? On the other hand, if I'm 99 years old and have, dementia, contractures, terminal disease, I don't want CPR. And what's involved in CPR when I do this talk in public. And all this, I show them what CPR is really about because I'm the guy who's to take responsibility to put the airway in like you do. I was the one who's starting the central lines. I was the one ordering the chest compressions, and you feel all the ribs crack and all that stuff. And if it's appropriate, it makes sense. But and I know so much of the time it doesn't. And on TV, where they have a 90% success rate, in real life, it just isn't that. So everything is the full court press. At times it's appropriate, at times not. Who decides? Who decides? Well, if you're awake and alert and oriented, you get to make the decision. This all becomes operative when you can't make decisions because you're not around or you're under general anesthesia or any other reason. And on the other side of this, now, this is a key part. Hospice and palliative care early is very useful and should be obtained. There was a study in the New England Journal of Medicine in 2015. They had a group of patients with identical lung cancers. They got identical treatment, chemo, radiation, surgery, whatever. One half got early palliative care, which is how to cope and comfort and a bunch of other things, and the other didn't. The palliative care group lived longer, had a better quality of life, spent less money. Lived longer, had a better quality of life, spent less money. That's a pretty good medical trifecta. Hospice is, palliative care isn't necessarily all about end of life, but hospice is. That's when death is expected within 6 months. And hospice does so much more than just providing comfort to people. It may relieve the caregiver of burdens. There was a hospice where this elderly man wanted to skydive, and they arranged that before he died a few weeks later, but he wanted to have that experience. There are a lot of things that hospice can do. And I will tell you this, if I got a bad diagnosis now, let's say lymphoma, and even if I was going to live 2 or 3 or 5 years, I would start checking out hospice and palliative care now. The whole point of this is do stuff in advance. We all know, especially in our own family experience, when something happens, the last thing you want to be do is fumbling around trying to get into the system, figuring out who's who, making phone calls, which hospice to use, how do I find a palliative care doctor, all that stuff. You want to do that in advance as much as possible. So most people choose the middle path. As long as this is mine, as long as I'm kind of around, keep me going, give me pain relief. Now you can also put things in your advance directive that are not just medical. So mine also says, and I'll show you where you can get some good advance directives and walk you through this part. Mine also says, take me outside as much as possible. If I can't be outside, show me the outside. Mine says I want control of the remote. Here's some of the kind of music I want to hear. I want a bite of chocolate every day. I want vodka and medical cannabis. I want certain people, if they're willing to come, to visit me a lot. In my family, we have one annoying relative, and they're a good person, but they just run their mouth and drive me crazy. And it says, if that person comes, that's fine, but please be sure that their visits are not too long. I mean, you can do a lot of things in your advance directive. Here's the kind of music I want to hear, and so on. So there's a lot of other stuff there besides the medical choices. It's not just for old people. I'm old. But I'm still hanging on pretty well. But the three most famous cases are women under 30. And you know from your own clinical experience that, when younger people get in trouble, car accident, subarachnoid hemorrhage, overdose, whatever, trauma of some kind, it's way more complicated. And even then, it's helpful that people have an advanced directive. So my perspective is every adult over the age of 18 should complete an advanced directive, much like we do the other things that we do as responsible citizens. Now, I'll point out to you, you can change your advanced directive anytime you want through various systems. But when our kids turned 18, mommy and daddy gave them advanced directives and they completed them. This is a situation we also find ourselves in the emergency room, maybe you in EMS. I hope you can read the slide. It says there's somebody flailing about in the water. Here's the lifeguard convention committee, and they're trying to figure out what action they should take. I mean, this is what goes on every hour of every day in every emergency room, and probably you face it when you're out in the field. You don't want a committee making this decision. And frankly, it often can end up being a committee, and people who don't know you and don't know your values, don't know your desires, don't know what you want, and so on. So this is the current state. Lots of people are going to have Alzheimer's and various other kinds of dementias. All dementias are not Alzheimer's, but Ronald Reagan did speak about it. I wasn't a political fan, but I appreciate that he and Nancy were able to talk about a tough subject, and it made it much more possible for others to talk about. The first women to talk about breast cancer was pretty bold. The question is now, can we actually talk about the universal thing that we're all going to die, but we can actually do something about it? Let's do it. This patient has a very rare form of medical insurance. This is the slide to remind me that the next topic is can't talk about healthcare without talking about money. So there's a financial aspect to this. This is pretty much how we spend money in our life. Most of the money in our life is spent in the last months of life, something like 30, 40%. And if it's appropriate, it's fine. But we all know that at times it's not appropriate. So if this number could come down a little bit, maybe over here on the birth and child side, where you can really help people when they're kids and they're developing, that would be really a good thing to do. How do we usually control healthcare costs in medicine? Well, we create a system nobody understands. We have lots of people making lots of money, but not those actually doing the work down at the bottom. We burden taxpayers and businesses. We make it confusing for employees. If you aren't employed, it's very hard to find a place to get insurance. So this is how we control healthcare. Here's an opportunity to control healthcare costs by empowering people and respecting their values. It's a very different concept for killing out free forms. And I wrote an article about it. So Medicare is about 900. And if, by the way, if anybody wants these slides, I'm happy to send them to you. Just send me an email. I'll send you the slides. And then if you can't read it all now or don't follow it, want to refer to it later, you'll have it. So just email me. Medicare is about $900 billion a year. You're all paying those taxes for my Medicare benefit. Thank you very much, all you younger folks. And about $300 billion is end-of-life care. Now, what if 95% of Medicare recipients complete advance directives, probably more than 40%, which is the public, but it's not much higher, maybe 50, 60%. Every death that doesn't happen in an intensive care unit, if it's not needed, that happens in the hospital, save money. If it doesn't happen in a hospital, but happens in a hospice facility, and that's appropriate, that saves money. And if it happens at home, where most of us really want to be, then that saves even more money. I've made an estimate here. If we just reduced the end of life care costs, remember how much it costs, down by 20%, we could save 250 to $300 billion. Of that $300 billion, we could save 50 to 60 billion. Not by restricting care or raising taxes or making the system more confusing or dropping coverage, but by expanding individual rights and respecting them. That's a pretty good deal. Organ donation. I revamped the organ donation laws in Maryland as a legislator in 2008. It sparked the programs at Hopkins and University. And I remember it was a very complicated bill, but the most powerful part that convinced everybody was when somebody was testifying for the bill and said, I lost my child, but my child gave all their organs, and my child's heart is beating in the person sitting next to me here at the hearing table. I mean, it was so convincing. My advance directive says, whatever organs you want to take that'll help somebody, please take. But that's up to you. And you can limit it. And we have a very good organ donation system now in Maryland, although there's more that can be done, but it's pretty good. Medical school donation, where we all learned dissection of the human body, and maybe you learned some ATLS procedures, are donated bodies or unclaimed bodies. So that's good. No cost. You have to arrange it in advance. So most people don't talk about this part, but the third part, disposition of the body, burial and cremation, I'm going to spend a couple of minutes on because it's another one of those things that we collectively avoid. So this is a typical 10-acre cemetery. Think Druid Hill next time you drive by, right near your fire station. There's enough stuff buried there to build 40 houses, each with a swimming pool. Think about all the metal, cement, and wood and amount of lawn mowing they do. And I've never liked this also from another point of view. This is personal. The monument, the bigger the size, the more important you are, the more money you had, the more you're loved, theoretically. I think we're all equal in birth and death. And humans have had a history of, and there's the amount of stuff that's stuck in the ground. I'd rather put it to use. And humans have had a history of making monuments to the dead. It's something that we do. But, frankly, it doesn't appeal to me. I work too hard for my money to pour it into a fancy hole in the ground with a big monument. What about cremation? Well, cremation is basically taking carbon, us, and burning it at 1900 degrees for 3 hours, which what comes out the smokestack is just like any other burning experience. It produces a lot of carbon dioxide. In England, where they do a lot of cremation for whatever reason, it's 15% of their total air pollution is cremation. So as you can imagine, I am not for cremation. It's sort of touted as something, and look at that casket they're putting in there, that big, all that wood. What could that build? That could build, something better than just incinerate it. What a waste. So what's an option? Natural burial, green burial, something we used to do a lot when a family member would have the family graveyard. It's a way of caring that furthers environmental goals, aims. It eliminates toxic embalming, all this waste, biodegradable, locally sourced containers. I've been to a number of these. They're more family-centered. Actually, the family lowers the body. The gravesite, the cemetery usually digs a hole, but the family lowers the body. It's more of a participatory experience, and it's way less expensive. Typical cemetery might be $10,000, and there's a whole bunch of extra costs from time to time. This is about $3,000, way less. So for me, the only two choices are natural burial and donating body to medical science, which you have to arrange in advance. This is what a natural burial cemetery looks like. This is from Ramsey Creek, South Carolina. It was a family that inherited a couple hundred acres of land. They didn't want to develop it, but they had to, come up with taxes and insurance and all the stuff that property maintained, and they just decided to make a natural burial cemetery. And you walk along, and every so often you see a flat river stone. Now, you may not be aware, but there is one right here now in Baltimore County. Natural Burial Cemetery, Serenity Ridge. There's the link. There's one coming to Montgomery County. And if you want to get to Serenity Ridge, you just take Old Court Road out past Northwest Hospital, keep going till you get to Ridge Road, hang a left, and you go down some of that windy Ridge Road, and it's up on the right. Same story. Dr. Howard Berg. Some of you may know him, colorectal surgeon. His family inherited that land. They ended at beautiful 180 acres. They've cleaned it up, and 90 acres got deeded into Baltimore County, and they call it Serenity Ridge Natural Berry Center and Arboretum because they're planting, they got rid of the invasives, they're getting rid of them, they're planting all these trees. Birds have come back. It's a really calm, beautiful place, and you can't believe how nice and quiet it is, only a few minutes from metropolitan centers like Security Mall and Old Court Road and Liberty Road. So it's a really beautiful place, and it's more park-like, and it's paid for by these burials, and they're way less expensive, and they're really nice. So it's they're doing a lot of stuff there. It's worth taking a trip out. Get in touch with them if you like it, but you don't have to do that. There are conventional cemeteries around that are being converted with natural burial centers, but Serenity Ridge is the only one that's all natural and in the state, actually, that's operating at the moment. Now, unfortunately, may not be aware of wrongful life lawsuits. So far has not hit the world of EMS. Wrongful death you're familiar with. Someone goes to the hospital, they're supposed to live, they die, negligence is charged, they sue. This is that the clinicians did something where they violated a person's advance directive. And so there was a verdict here of a couple $100,000. My generation, the baby boom generation, wants it the way we want, and we will go ahead and deal with it more aggressively than others have. Also, we're living longer. Most people didn't, they were 70, 75, they were wrapping things up. I'm in that age range, and I still feel like I got 20 good years in me. So there's a whole group of people, big generational bubble that is living longer, happier, more productive lives. And they're very conscious about what's going to happen and what's going to happen to them. And they have the clout to deal with this. This is the story that really got my attention. There was a 91-year-old woman came to emergency room, and she had no resuscitative efforts wanted. Her granddaughter agreed. She had a pleural effusion. They tapped it. It was malignant. And then an arrest took place, and they intubated her. And she spent 2 weeks in the ICU till she died. The family sued down here at the bottom. They won $1 million. Now, I had to deal with trial attorneys in the General Assembly. They're a very smart, shrewd group, and you see their advertisements, Camp Lejeune water, talcum powder, birth defects. I saw one recently, a billboard said, I specialize in suing Uber and Lyft drivers accidents. If you're in an accident with Uber or Lyft, that's my specialty. In the medical world, there are now people who specialize in this. And there are a lot of cases. You don't hear about them because the litigation funnel takes a long time. That process takes a long time till it comes out the other end. But they are picking it up. And I have an acquaintance who's an MD, JD in New Jersey. He's seeing 4 to 6 referrals a month now. So people will add this. I've added this to my advance directive. If I happen to be someplace where they're not recognizing what I want, I tell my healthcare agent to seek appropriate action and replace anybody. But at some point, this may translate out to the EMS system as well. You have to be familiar with the MOLST form, which we'll get into in a second. Right, that's the second. So you know that MOLST is the DNR, do not resuscitate or allow natural death order. And it's valid across the continuum of care. I'm sure you've been dealing with this. It's still a kind of a work in progress. How they get filled out, who fills them out, are they available? And you're going to have to be more aware of this because there's just going to come up more and more often. It's especially going to be important when people get to the emergency room that these are available. So here's where you can get advanced directives. There are many sources, Attorney General, AARP, there's faith-based, but the best one, in my opinion, is mydirectives.com. It's free to individuals. It's the only one recognized by the Maryland Healthcare Commission. But you could complete that, and it's still, you have the thing that has to happen is advanced directives have to be completed, whatever version you want to use. They have to be available, not hidden in a safety deposit box or a filing cabinet, but available when needed to EMS and to ER doctors or wherever the patient is. And then we need to learn to honor them. We clinicians need to learn to honor them. I mean, I've seen clinicians make very tough decisions in a whole range of cases, and then there's an advanced directive and they become unglued. They don't know what to do. So we're going to have to learn this stuff because it's coming and it's here, and we're going to have to catch up as best we can. My directives puts a QR code like this. This is what I carry when in my wallet. This is in the glove compartment when I go out jogging, when I'm traveling. What happens if I'm actually going to speak to Texas on this subject in the next week? What happens if I get in a car accident there? Who are they going to call? Even if I'm in Maryland, it was in Southern Maryland. I mean, most of my health records are in the Baltimore area. What do they do? So this not only has my advanced directive, it has all my medical information I plug in and who to call, wife, kids, family members, and so on. This is what I recommend to all patients. This is what I have by my front door. A medical go bag. The first thing, that we have to do in the emergency room, if the patient's stable, we scurry over to the computer and try to figure out what's going on here. What's the history? This is the key information that we need to make medical decisions. So I tell folks, just print it out, have it for EMS. Yeah, you guys, and bring it to the hospital. So give it to the nurse, the PA, the doctor right away, and they can know, save all that time and then pay attention to you and try and figure out what's going on without having to say, what's that last EKG look like? What medicines is this person on? Oh, they're on a blood thinner. Well, is it aspirin, Eliquis, some other one? I mean, these are the challenges. I take an antibiotic. Which one? Well, it was, something. I don't know. This is the kind of information that, we can just take responsibility for having for ourselves or, tell your family members. So we need to do all these things. This is what needs to happen. I think of advanced directives like a seatbelt. I mean, you could be in car accidents, not wear your seatbelt. You'll be fine. You'll be in car accidents where wearing a seatbelt won't make a difference. You're still going to get killed, tragically. But most of the time, having a seatbelt makes a big difference in your safety in the event of a car accident. An advanced directive is not a perfect document, but it shifts the likelihood of what's going to happen to you to something that's more aligned with your values, needs, desires, and respects your family and your own personal values. So, this is something that we are empowered. Nobody's ever had this opportunity before. We are empowered, and all this is free. I mean, hospice is covered by Medicare. Palliative care is covered by insurance and Medicare. Advanced directives are free since 1991. The hump we have to get over is we have to be able to talk about death. And that's a subject we collectively avoid. And I bring it up all the time at the gym, the grocery store, in a restaurant. This conversation, I'll be speaking at MIMS, I'll be speaking in Texas. I mean, this is the discussion to break it down. And I think of things in my own life and career that seemed impossible and weird at one point that are normative now. And in my first election, I got elected in 1994. So the General Assembly meets in January. So January 95 is my first term in office. And there was an issue that was so controversial. I mean, I'm just trying to find my way around and how this place works and meeting other people. There was an issue so controversial, I couldn't walk down the hall. Someone would come up to me and say, Delegate Morhaim, you got to vote for this bill. It's the most important health care bill ever. And I walk down the hall a bit more and someone come up to me and say, you got to vote against this bill. It's going to destroy the Maryland economy. There were thousands of people out of work. What was the bill? The bill was to ban smoking in restaurants. Yep, smoking in restaurants. Real controversial. Months of argument and heated debate about that. Well, tightened our belt. We voted to ban smoking in restaurants. And guess what? I mean, health got better and the restaurant industry, in fact, did not collapse. It improved. More people went out to eat. It took 10 years to ban smoking in bars. Now, I was not the point person on that. Another delegate kept putting in the bill. I was supporting her, but it took 10 years, went through the same arguments. You couldn't introduce legislation now to say, let's have smoking back in bars and restaurants and all other public places. People would think you're crazy. There's so many things like that that happen. So this, I believe, will become normative, but it's going to take the work of all of us to do that. And the work here is easy. Go online, pick the one you like, and complete your advanced directive, and then bring it up to everybody you know. Now, they may run the other direction. I get that. But they'll often come back to you later and say, thank you for bringing it up. I'm ready to deal with it. So, to get all this saving money, comfort caring, family-centered, holistic experience, empowerment, respect for personal values, to get all of that, essentially free. So why is this so hard to sell? I don't know entirely, but I'm counting on you to jump up and do certain things. National Healthcare Decisions Day, April 16th, coming right up. The people who thought of it for April 16th, not me. April 15th is another day we tend to remember. Taxes and death and taxes. So they linked it that way. And maybe you could have an advanced directive signing event at Pikesville Volunteer Fire Company. Maybe get all the volunteer companies to do that. People look to you as leaders. EMS is widely respected. You deal with this every day. Your role is key. If you bring it up, believe me, everybody's thinking about this to some degree or another. People know about mortality when they get to be about 10 or 12 years old. And yeah, some people are going to look at you strangely, but someone has to break the ice and start the discussion. The first people who said, let's ban smoking in restaurants were weird. The first women in 1848 that had a convention that said, we want the right to vote, which didn't happen until 1919. I mean, most of them were dead by it happened, but you know, there's some things about women's rights that are going on, but taking away the right to vote isn't one of them yet. I hope not. But the person that starts this is us, is you. And this should be part of the thing I think that everybody that's in healthcare needs to break the ice, whether you're an orderly in the emergency room or a unit clerk on the floor or a nurse or a doctor, PA or EMS. It's up to us to bring this, and the benefits will accrue. This was also proven in a town called La Crosse, Wisconsin. La Crosse was about 120,000 people. Think of like Frederick, Maryland, and the various communities, business, health, faith, medical, and some activists got together and they said, we're going to be the town that they call it has the conversation. They raised the rate of completion of advanced directives from the standard 35, 45%, 40% to 99%. They just made it a commitment. And here's what happened, two things. One, people looked at each other differently because there was a little, when you think the great sages and philosophers of history and through the world, spiritual leaders, the contemplation of death makes you appreciate life. And so people start seeing each other differently. They weren't quite so rude. The person bagging your groceries, if they were a little slow, you didn't get as angry, that kind of thing. The other thing is they reduced their healthcare costs by a third. They actually proved it through the Dartmouth study, which monitors healthcare costs. So we can do that. It actually has been done in other communities now since. So it saves huge amounts of money. It respects individual rights. It's a powerful concept. It provides an experience that we've been cut off from, but ought to be part of and participatory in the loss of our loved ones. It's going to happen, but we can, put our heads in the sand or deal with it proactively. Now, I did want to share this because you deal with it. This is just a few weeks ago. Maryland leads the nation in ER wait times. I know that because I used to see you guys lined up in the hallway. Please check out this article. What we suggested is the problem with, and anybody that's worked in ER long enough knows, you don't get the admitted patients upstairs. A third to half the beds in the ER admitted patients, they're sick, they take a lot of time and energy, can't ignore them, because they can't get upstairs because the beds aren't turning over. Why is all this happening? Because there aren't enough nurses, orderlies, techs, and all the other support people that make an emergency room run, dietary, housekeeping, clerks, and so on. What do hospital executives make? What do you think they make? I wish I could see you all, but you can look it up. It's on the Health Services Cost Review website. And hospital CEOs make millions of dollars. The head of MedStar makes $15 million a year. The head of LifeBridge makes $3.5 million a year. And underneath them and all the other places, there are legions of people that are making generous seven-figure, high six-figure incomes. In my opinion, they don't need to make that much money, especially because whatever they're operating, it's not the ER's fault. It's not the MS fault that the ERs are backed up. They have to take responsibility. Of course, they're often corporate suites, not dealing, 2 a.m. with what you and I deal with. So we suggested in the article that all their incomes be capped at $500,000 a year, which is a comfortable living wage. I mean, I would roll out of bed for $500,000 a year. But if every CEO and executive in Maryland administration was making 500,000 of what they're making, we would be able to hire over 1,000 nurses throughout the state. And all the other people that make it. I had a routine hernia operation a couple of years ago. Jeff may remember because I talked to him about anesthesiology, and everything went fine. But then it took an hour for somebody to come with the wheelchair to wheel me out. I was ready to walk out at that point. I was physically able to, but I had to wait that hour. Well, that hour compounded, rippling through the whole system is what leads to this. And I don't believe anybody should be making that much money when they haven't fixed the problems. Read the op-ed, co-authored by David Myers, who many of you may know, who was his chair of emergency medicine at Sinai for many years. So there's my contact information, and we're done there. So I'm available to you for questions, comments, personal attacks, whatever you like. There's more to be said. I can't get into it all. There's medical cannabis, there's assisted dying, there's a whole bunch of other issues, but you're on the front lines. People love and respect you. And if you're the ones that bring it up, you're going to change attitudes. Okay, Jeff, back to you and anybody
So
else.
I'll start before we start. We'll get some questions in the chat, but the first part, HIPAA. I can't talk about your hernia surgery.
But I can.
You can. Um, but one of the things I found very interesting, and I heard this many years ago, and you can tell me if it's true or not, but I'm pretty sure it is. I was told, and this was before the Maryland Mulse came out, that more than 90% of your Medicare dollar is spent in the last 30 days of life.
Yeah, I basically showed you a statistic to that effect. I mean, whether it
Right.
depends how you count, 90%, 70%. Right. And if it's
But I'm saying
appropriate,
specific Medicare dollars,
yeah,
just the
that's what
Medicare.
that was my slide. I can go back to it, but yeah,
Yeah,
that you're on track. And if it's appropriate, it's fine. But
yeah.
let's be honest. I mean, at times it just isn't, you know,
I,
and we've all seen that patient and that's an issue.
Well, I remember working as when I was as a resident, as a fellow, and as an attendant, you would have patients with certain diagnoses, and everyone knew there was nothing that could be done except to make the patient comfortable. Yet there would always be a family member who wants everything done. And as much as you thought you were creating pain and suffering for the patient, and you weren't accomplishing anything, but you did it because there was always somebody who said, do
Well,
absolutely everything.
when a couple of things. One, you're going to find yourself on the receiving end of a wrongful life lawsuit. But let me say let me
Well, this
tell
was
you an
before
anecdote
Moss.
let me tell you that changed my life on this subject. Many years ago, the call came from paramedics, a little old lady found on floor. It was clear she had it was a demographic, an older woman living alone. The EMS recognized immediately that she had a major neurological catastrophe. We were ready for her in the ER, did all the stuff, but it turned out that this is hours of work, getting on labs, scans, consults, neurosurgery. And she does have a massive intracranial hemorrhage from which there was no recovery. The call goes out to the family, and family starts drifting in. We put them in the quiet room, and I'm keeping them informed as it goes on. And what I observe is, a lot of family tension comes up, and some people said, "Do everything for her." They're usually ones who weren't around much. The ones who were around Grandma more said, "Let Grandma die in peace." And then there were a few, like stuck in the middle. And people will carry these arguments and these bitter things, for the rest of their lives. Sometimes you may know families where that's happened. But it turned out she had an advanced directive. It was one of the first ones I actually ever saw in an emergency room. So I read it and it said, if I'm dying, no heroic efforts. And there's no hope. I want no heroic efforts. And there clearly wasn't. So I went in the room and, some people are arguing. One person's standing in a corner holding their face, sobbing. And finally, they all look at me. It's time for the doctor to say something. And I said, look, appreciate all the points of view, but this is like she's talking to me. I'm honor bound and legal bound to follow. So I'm going to go in the room and I'm going to take the endotracheal tube that I put in out. I'm going to stop the medicines that are keeping everything going. And you can come in the room with me. And you might think at that moment it gets more hysterical. Actually, everybody calms down. The decision got lifted from them. We go in the room, I disconnect everything, I drifted to the back room and watch what happened next. And the family gathered at the head of the bed and they whispered things in her ear. They held her hand, they stroked her brow, they may have said prayers, done other things. And I was able to watch for about 10, 15 minutes. And this family that was at war with each other now came together. We are a very me-oriented culture. It's all about me, me, me. What this woman taught me, and she gave this gift to her family. If you really care about your family, you'll take care of this. She did not leave them in the lurch. If advanced directive is operative, you're not making the decisions. If you're awake and alert, you're making your own decisions. And yes, there's always going to be family conflicts. Nothing is perfect, but most of the time you can address a lot of them. There may be one person. I've stood up to some people in saying, this is what it says, and I'm going to do it. And if it gets too heated, I get a social worker in, I call the hospital attorney, whatever. But almost all the time, you can calm everybody down if the person's wishes were known and you advise them that that's what we have to respect. And if you don't, you can be on the wrong end of a lawsuit, potentially. There were a couple of comments here about CRISP. Yes, they're supposed to be loaded into CRISP. It's not working yet. There was legislation passed after I left the legislature to do that. It absolutely should be there. That's an excellent point. Andrea Levine and BCVA MRB. We need to do that. It should be in CRISP because each system has their own way. So there's a lot of work still to be done in this arena on that regard.
Also in the chat from Andrea, she points out, which is very, very true. Social workers within the hospital are an excellent resource for
Yeah,
questions about advanced directives. And I
she's right.
believe most hospitals, as part of their admission packets, will offer an advanced directive packet with it for
And they
people
will
who do not have
offer,
their own.
they'll often ask you, by the way, hospital chaplains are great too. Don't want to
Yes.
forget them. They do really well. I've used the ones at Sinai, Rabbi Ackerson, if you know who he is, and others. But the thing is, sometimes what happens in the emergency room, at any rate, which is where the world that I know, you're coming in, you sprained your ankle, and they say, blah, 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 register. Oh, have you completed your advanced directive? The patient's thinking, well, what about my sprained ankle? Aren't they telling me? They're giving me this death thing. But I think we have to mention it everywhere. Again, I bring it up all the time at all settings possible. I'm doing a talk on anemia that we were talking about before. I have 2 advanced directive slides at the end of it. Nothing to do directly with anemia, but I put it in every conversation that I can.
It's part of
Brian
the
makes a good
registration.
point. Let me say, Brian makes a really good point. It's a deeply cultural thing. I didn't get into that aspect, but yes, you have to respect different cultures on this, and that's just we deal with all kinds of people. You do too. Old people, young people, rich people, poor people, people of every background, ethnic, race. And we flex and adapt to them, and that is important. The more that they convey to us what their wishes are, consistent with their values and spiritual and culture, the better we can service them.
There's in the chat from Akiva Hamburger. It seems like the cost of any state-led effort to have Marylanders provide an advanced directive information would more than pay for itself in healthcare savings. The state does make a lot of contributions towards Medicaid. Has there been, or is there any legislation in that effect?
Akiva, great point. Yes, but it hasn't all been followed through. So the ones that passed a couple of years ago was to have mydirectives.com, well, actually to have a unified database for this, which would be CRISP. Now, I don't understand all the pieces that haven't fallen into place, which is why I always make sure I have my own advanced directive and my own medical care bag, because you can always take personal responsibility for this. But you're absolutely right. It should be happening. And it isn't, but you may travel out of state. You go to Virginia, you go to Ohio to visit your cousin, then what? So these are all issues that I think will be addressed, but you're absolutely on target with that. Yes, it would save a lot of money. We did get National Healthcare Decisions Day passed, my bill, that recognized it officially in Maryland. So maybe on April 16th, if not, you can't get it together for this year, but maybe for next year, because people will still be dying in 2025. There's no doubt about that. Maybe you can coordinate with all the fire companies and or at least the Pikesville one to have something public about National Healthcare Decisions Day and why you should. I've written the governors and said, why don't we do this? And maybe they will at some point tackle it. But it's just like that smoking thing, as a big deal. I hope that one day advanced directives just become normative, become a normal part of the record. We won't have these concerns and discussions about it because it'll just be something we all do. And most of the time it's going to be helpful and sometimes it's going to be difficult. But most of the time, like wearing a seatbelt is going to make things easier.
All right.
Anybody else? Questions, comments, suggestions, personal stories? Show of hands. How many of you completed your advanced directive? Jeff? No? Class assignment. Class assignment. I'm going to hound you all the time. Come on, come off the screen, everybody. Let's be raise your hand with the little hand raise or something. I mean, you are the leaders in healthcare. You see what it is when,
Together, right?
yeah, a few. I mean, this audience should be 100%, and we have to lead by example. And there's something interesting that happens when you complete it because it actually makes you think about certain things. Then you put it away. I mean, you file it, you keep it someplace, you make it available. I give one to my doctor. I try to make sure they're in my records, and then I don't think about it again. I mean, it's just a safety net for communication. It's a safety net for respect for your values. It's a safety net that you get the healthcare. They call the right people, not just talking to somebody. So please try and make it something that you tackle. Only you can complete yours. I mean, nobody else can do it. So Carol Ann says, I have a MOLS form and advanced directive. Yeah, most forms are not required unless you're a person who goes to a lot of through a lot of regular healthcare, like you're on dialysis in a nursing home and so forth. That's what most forms are designed for, to go a little more in depth. Advanced directives are what a patient wants, but you can't anticipate every medical circumstance, all the complexities of medical care. So that's an order written by a doctor, nurse practitioner, or physician assistant that goes into depth. Tanka writes, so thank you, Carol Ann Ballard, for having that. One of the other things I like about mydirectives.com, free and online, just name and password. Every year they send you a little reminder. Hey, time to update your advanced directive. Maybe something's changed in your life, your health, your values, your relationships, whatever, your spiritual orientation, who knows? There are little tweaks that I've done with mine. Andrea Levine, if you find yourself no longer in a relationship, make sure you change your healthcare decision. Exactly what I was just saying. Andrea's on top of this. Tanika, I haven't done so yet, but I am an organ and tissue donor. I get weird looks from people when I tell them I aspire to become a hospice nurse. Thank you, Tanika. That's great work. There's people who do work like that I couldn't do. I can't believe that there are people who can do pediatric hospice. I don't think I could handle it emotionally, but there are people who do that. So, it's very rewarding work. Very rewarding work for those who are oriented that way. I mean, I like emergency medicine. That's what I chose to do. I couldn't do what Jeff does, or I wouldn't mind be a pediatrician, but I like doing a little of everything. I get to intubate Jeff, but do all the a little bit of everything in the ER. But yeah, you won't get weird looks, Tanika, as time goes on, because this is going to become more and more normative, just like not smoking in public places or wearing a seatbelt. I was around for, when you had there was discussions about if you have a baby in a hospital or a birthing center, you have to have a bucket seat, to take it home. People said, "Who are you, the state, to tell me that I should put my baby in a seat? And we're going to give me the $200 for the seat and all this stuff." Motorcycle helmets comes up every year. Let's get rid of motorcycle helmets. It doesn't pass, but we work through these things over time, and I think this will be the normative if all of us, all of you, are the ones who will bring it up to everybody over the age of 18 in every circumstance. Now, people my age, we tend to think about it, but even we aren't very good at this. But again, the three most famous cases are women under 30 in American medical legal history: Cruzan, Quinlan, and Shivo. What is the link? I will type it in the link for everybody. My directives.com. The other thing that's good about mydirectives.com, besides being free, if you have, let's say you have a devout faith, you can complete your faith-based one and then upload it into my directives. You can also do a video in there too. So there's different things you can do with my directives that you can't do with others. My contact information, please. Sure. I mean, I live very close. I go by your facility all the time, and I really appreciate what you do. Sometimes people say, yeah, I mean, I mean, where I deliver healthcare, I'm in a nice, brightly lit room with safety and security, and people are on beds. There's all the tools. I don't know how you guys go up and down, stairs and take people out of car wrecks and pull them out of burning buildings. Hats off to you. That's a job I couldn't do, but I'm so appreciative that you do it. I do have a brick at the fire company. I donate money to you on a regular basis, and I will be sure to do another. This is my free talk for you, but I will definitely be sending some contribution in. And when I run in these 5K races, I like to see Jeff there, performing more community service with the whole gang of your folks in case, something happens, you're there. And I thank you for being patient on the technical parts. We ran over time a little bit, but I don't think I ran over time, but the conference did. But so many of you stuck with it. And I look forward to seeing you around and hearing from you. Jeff, what else would you like to do, or anybody else?
So there's a link in the chat for people to fill out if they would like some continuing education for this. That way we'll be applying for some MIMS credit. That way it will help with your recertifications, which occur every year. Some people just started a new cycle back in January. So fill that out, please. We'll stay on for a couple more minutes. If you have any more questions for Dr. Morhaim,
Well, just go on
please type it.
wherever you do it, go complete your advanced directive. Make sure it's available. You do it, it's available. That's and once you do that, you'll find it easier to talk to other people. It's hard to talk to people if you're not doing it yourself. Gotta lead by example.
Other than that, I thank everyone for their patience tonight and attending. Um, hopefully the link will be proper the next time we send it out for the next one. More information will be coming on that in the near future. Thank you again, Dr. Morhaim, for joining us again.
Thank you for your service.
We've been on
Love
a
being in your neighborhood.
40-year journey together.
Yeah, it's amazing.
My gosh. And hopefully we still got another good 20 plus years in this.
I'm planning on it. Thanks. Thanks, Jeff.
All right, thank you very much.